is going to speak with you today. Also, Elise Cutter, our Chief Financial Officer. We also have Dr. Gary Preston on the line, and he will be helping us with some questions at the end. Ann Raish, our Chief Operations Officer, and myself, Jeanette Papadakis. And we will go through first sharing some great news with you. There's been a baby boom at Island Hospital during this last month. In fact, on Tuesday, we had about 14 moms here. I think it might have been a revolving door. And as we're all adapting to new things in our lives, near the foundation office, we can see relatives and grandmas peering through the window to see those little ones occasionally. So this is some cute shots that we were able to get. So really neat news there on labor and delivery with all these new lives. Now, I wanted to share a little bit with you and thank our community. We all know that we live in an amazing community, and it just shows at this point in time, too, in the last month here. Here's some of the donations we've received for the supplies we've needed, like the gloves, masks, face shields, goggles. We've got so many sewers out there helping us with the new masks that we all need to wear around the community. It's just been overwhelming. We've also received so many meals from, look at the list of all these different establishments in town, restaurants and individuals, flowers, orchids, groups getting together. There's even Nicole Skelton and her husband doing a GoFundMe page to raise money to feed our staff. So when this is all over, I think we're going to really see, we're going to need Weight Watchers. But it's been really heartwarming. For our emergency relief fund, we've had 111 community members donate to that, so it can help us really be prepared, and it's been invaluable. So I want to thank those 111 donors for contributing. Some of the things we've been able to do because of those generous donations are expand the critical care with 8 new ventilators. So we have a total of 12 ventilators and 2 transporters. And what's so cool about these new ventilators, they're going to help us not only now, but into the future, because they do so many things. They provide the ventilating system, but an oxygen concentrator, cough assistant, suction, and a nebulizer. And before, you used to have 5 different devices that would be able to get these functions to patients in need. So they really will help us in the future as well. Then with the tele-ICU donation we received, well, it's going to help strengthen our critical care. It's giving us a higher level of specialty care with adding an intensivist, and it will keep care here locally in the future. It's something that's going to help us now, but also in years to come. So this is really an awesome program that we can increase the level of care people will be receiving in the ICU. Then telemedicine. We also were able to get some help with telemedicine. And that piloted last week. And we'll talk about that a little bit more in the presentation. But so far, with telemedicine, I know Dr. Prince told me it was going great on Wednesday, and I even had a patient friend write that she loved it. Her first visit was this week. She said she liked that she didn't have to drive to her appointment, she didn't have to wait, and her provider was on time. So she's a real busy person, and she said it went great for her. But we'll talk about that a little later. Next, I want to turn it over to Charles Hall.
Good afternoon. Happy Friday, everyone. A chance to take a look at, there's 57, maybe that was 58 folks that have joined us. I'm truly grateful for this opportunity to speak. My wishes and my hopes are that your families are doing well, and that the hopes are we can meet in person in the near future and start gathering as this pandemic moves toward a recovery phase. I want to thank Jeanette and the Foundation for all the great work they've done in reaching out to the community to help fill the need and champion all the support that has been coming to our hospital and to our people. I'm constantly amazed about the generosity we've received and the dedication from our providers and our staff who day and night continue to fight the battle. I want to give a quick little perspective on fighting the battle. You know, we've not have taken a direct hit, but we'll end up talking a little bit about Island Hospital's numbers. But needless to say, in caring in this environment weighs heavy on the soul. It weighs heavy on our staff members who work with patients who come in with runny nose or itchy eyes, or fever, maybe a cough, body aches and whatnot, not knowing if this individual is COVID positive or not, but making it a little bit more personable as they come home and they have to strip down before they come in the house and take a shower so they don't infect their family. These are scary times for our community and scary times for the hospital, and I know that this pandemic has weighed heavy on all of our souls, and I'm absolutely grateful for all those who support the hospital, but especially all those who have manned the front lines, answer the call to fight this battle to help us be successful ultimately in this journey. I have a picture up in front of me. This is Dr. Hogue, a good-looking fella, here kicking off telemedicine, and got a chance to speak with him, and he's really excited about this new service. This telemedicine service, which we'll talk a little bit later on in the presentation, is a new service for Island Hospital. It's a service that was not possible in the past due to the regulations of rural hospitals and some of the designations that we have, but now that those restrictions have been lifted, it's a new service for us, and our providers and our staff are eager to embrace it and to roll it out to the community. But this is Dr. Hogue that's in front of you. He's one of our primary care providers. One moment. I've done a number of presentations to the community as well as to our leadership. So for some who have seen pieces of this presentation before, I think it's important to kind of understand where we are. We're going to send out this presentation out to this group, but at the bottom of some of these slides is the web address. This web address is 91divock.com. It's COVID-19 spelled backwards. This is a visual interaction of Johns Hopkins data from each of the states and public health departments as it rolls up. It shows actual, and so for us, this is the top 50 and where we are in the United States. It shows our curve as we work to flatten out the curve as we move forward. This is Washington State active cases. This is as of this morning as I pulled it. What's really awesome to see is we're flattening it out. The thing that some people end up missing is the acceleration, that first part of the curve. The first was the 30 days as we kind of went through this period of time. And so the good news is that acceleration seems to be dying down as we move forward. This next slide that we're talking about is Washington State deaths. You'll still see an active trend line going into an upward trajectory. With that being said, you know, our goal is to continue to prevent death. This is another one of those slides. This is from WISHA, Washington Hospital Association. The web link is down below. It's an interactive website, so if you had a chance to log on to it, these represent each of the counties and the number of positive cases. To the right, you'll see select cases or deaths. You can actually drill down on the deaths by county and be able to truly understand either the migration of COVID going in one direction or another, but also the forecast of the curve. With that being said, as of April 15th, it usually is 1 to 2 days behind. Washington State has an 8.7 positive test rate, 91.3. Those that are tested are negative. This puts it in perspective. As of yesterday, the website is generally updated 4 o'clock to 5 o'clock every day, Monday through Friday. So as of about this time yesterday, in Skagit County, there's 218 positive cases. 30 are hospitalized or have been hospitalized. There's been 6 deaths, and 75 have recovered. Down to the bottom, Skagit County positive COVID cases, that trend line, bottom left graph right there, really is the positive cases as we move forward through time in our county. March 1st through April 15th, and it's year-to-date cumulative as we move forward. It shows a trend, and as of about a week ago, you see that trend leveling out, and this week we've received a spike. There's been about 3 or 4 days in the last 7 days that we've had 6 to 9 positive cases in a 24-hour period of time. We know that the incubation period of time is generally 10 days, sometimes a little bit earlier, sometimes a little bit later. It's done by droplet or airborne, meaning the coughing and the sneezing that people have becomes highly contagious. Any social gathering that occurs, whether that's at home, at the grocery store, out in the community, in the workplace, and so forth, can really infect others. And it looks like about a week and a half plus ago, there was a group of folks that got positive COVID. When we look at the numbers with the public health, we ask questions like, was this in one location? Was this, in some cases, an assisted living home? Was this a specific employer? In the last 2 weeks, this was not cluster. This was cases from all over Skagit, Snohomish, and Whatcom County. So this wasn't isolated to one specific geographical location. To the right, bottom right, you'll see 39.4% increase. This is part of the WISHA COVID tracker. This is a forecast tool. So as of Wednesday, April 15th, you'll see that over the next 10-day period of time, they forecast a 39.4% increase in positive cases. Now, how does that compare to maybe late in March? To the bottom, you'll see it's decreasing over time. It peaked with the forecast on March 28th of 111%, and now we're at 39.4%. So yes, we're flattening the curve. Have we reached our peak? Are we toward recovery? That's something that is still going to be debated for a time. You'll see here momentarily that we are predicting more of a plateau more than a peak, a fight with the COVID until treatment or a vaccine, stronger treatment or a vaccine is discovered. So where is Island Hospital today? This is as of today. These are all of our positive cases against our negative cases. So it's kind of hard to tell depending on the screen that you have, but the light blue are all of our negative testing. We've had 425 total tests. Out of 425 tests, 22 were positive. 5 were inpatient, 12 were outpatient, and 5 came from the emergency department. This is one of those predictive modeling slides right here. Well, lots in the slide to digest here. I do want to start out with the upper right slide, the graph that's up there. We've seen samples of this flattening the curve. where there's a peak, and without any intervention, it can overwhelm our healthcare systems across the country or a region. By social distancing, by wearing of masks, by washing our hands, we can flatten the curve. I believe the biggest lesson in all this is more so about the risk of resurgence. We believe that we are flattening the curve by all the social interventions that we've placed on our society, but to what extent? And so as we get out to the warmer weather, as we go out to the hardware stores or to the supermarkets, as maybe we spend a little time walking through the neighborhood and saying hi to our neighbors, you know, our attention span as a society is fluctuating, and it's becoming harder to contain this virus. As you saw a few slides earlier, in Skagit County, we continue to have more and more cases. As we go out to the community, we have a mixed response of those who wear masks and those who don't wear masks. From my point of view, it's extremely important to continue to social distance, to stay at home when possible, and to wear your mask when you're out in the community. This right here shows a trend. The bottom Island Hospital Predictive March table that I have in there, that graph, was what we were thinking about last March. We were thinking that there was a peak and there was a recovery, that we would conquer this, because we didn't know too much about COVID, but we would conquer this and we'd be opening up our services back in June. What we're learning is that this is going to be around for a while, that we're still searching and working to develop a vaccine, to develop better testing models. We have the federal government laying out how to open up America again, but through some phased measures. I think there's a total of 3 phased measures, but when you really look into it, it talks about continued social distancing as we go into businesses like restaurants and gatherings and grocery stores, that it's a slow opening up through social distancing so we can not peak and overwhelm our healthcare system. As we take a look at, is this seasonal? Well, the red line above really says more plateau versus the blue line says there's a dip. There's a variance out there in thought on how are we going to handle it as a society, or does COVID decrease in warm months similar to the flu? I think there's some scientific answers that are out there, some that vary from one end of the spectrum to another, but one thing is certain, that through social distancing we can flatten it and we can reduce the positive cases that are out there. Personally, I believe we're probably going to sustain a plateau once we plateau as we go through this. There's a number of steps that we would do to open up society and advance services through the hospital, and that's bringing back elective, non-urgent procedures. We would still have to have PPE. We would still have to have screening stations, as we believe COVID will be here over not only the near future, but the distant future as well. These growth rates that are found within the curve, these come from WISHA, from that tracker that I showed you in the previous slides. King County currently, over a 10-day period, is 19.1% growth rate. Snohomish, 21.8%, and Skagit, 39.4% over 10 days. We've been asked by Washington Hospital Association to start truly planning what would it look like to return services to Island Hospital. We'll answer that question here in a moment, but what I would end up saying is we are currently planning to do so. Our hopes are in May, once we get the go-ahead from the governing authorities. What does recovery look like, and what are those triggers? As we close down society, as we reduce services, as we canceled all elective non-urgent procedures, this was done through the CDC, through the Department of Health, through Washington State, our governor, as well as supported by Skagit Public Health. We would need a recommendation from these governing entities to start elective and allow us to return our services back to the hospital. As we've talked about Washington Hospital Association to look at what those guidelines may look at, it would be things like no harm to patients, and these are for our elective procedures from 3 months to 6 months. Well, what does that mean? Well, right now, our elective procedure guidelines are if a procedure can hold 2 to 3 months, then we should hold off on performing that procedure. If we say to 6 months, then it becomes harder and harder to postpone procedures, and we can start opening up our surgeries again. From a hospital point of view, procedures with less than 3 days length of stay would be another trigger. Establishment of a discharge plan, going home, recovering and isolating even if you're positive, and then adequate PPE for greater than 30 days. Where are we right now? Well, we're planning, being very proactive as we plan our strategy moving forward. Hardwiring telemedicine and our tele-ICU rollout. The industry's demand for PPE is a little bit concerning. Right now, Island Hospital is comfortable with our PPE under current conditions. As we open up more services in the future, the demand for PPE will be great from the other healthcare entities, and it may become harder and harder to receive PPE from vendors. It's probably the biggest thing that keeps me up at night. Can we start elective procedures? Absolutely, I believe we can. Can we provide amazing care? Absolutely, I believe we can. Do we have the right inventory if we open up society and our vendors, our supply vendors, can't send us the needed replenishments? That's where the challenge is. We're currently working to schedule patients into our clinics through telemedicine. We've talked a little bit about PPE coverage of procedures. We are still planning on opening up the urology clinic in the next several weeks, and in an active conversations with additional GI providers to meet the demand of this region. And then on the backside, in some ways, some of the most important things, our team, we know that I'll use words like low census as well as or furloughed. About 20% of our workload that we furloughed are low census because we've reduced our revenue that's come in, that the patients aren't here. We have to take a look at the anticipated volume and then welcome our team back to the hospital as we up our services again. I want to briefly go over, there's a lot here. We'll get a chance to send this presentation out to everyone. What is that roadmap from a healthcare's point of view to open up society again? There's several models that are out there. In fact, I think yesterday the president rolled out opening up America again, and there was 3 phases. American Enterprise Institute also put something out there on the national coronavirus response on what is it going to take to open it up. There's a lot of different models out there. I don't want to marry myself to one model or the other, but I want to be able to kind of walk through the high level, what would it take to begin opening up society, bring services back to the hospital, have elective procedures here. Phase 1 seems to be consistent no matter which model that you're looking at. It's to save lives. It's to slow the transmission. It's to provide additional testing. It's to make sure that there's enough equipment and supplies for facilities to care for those in need. Those next steps generally look like this right here. Is there a reduction or a control of coronavirus over a period of time, 14 days, incubation period? Is that going on within our region? Well, for Skagit, in that slide that I showed you prior to that, we continue to see a rise in new positive cases. We have not met in Skagit County this criteria to really think about opening up until we can stabilize and reduce new COVID cases. Capacity of hospitals to safely treat all patients requiring hospitalization without resorting to crisis standards. We're able to meet that, but I do want to talk about what crisis standards, generally this is called crisis standards of care, And crisis standards of care is an ethical consideration when there's a disaster, a medical or a healthcare disaster response, where there is more demand than there are resources. At Island Hospital, we at this time feel comfortable that we have all the resources that we need currently to care for patients that are coming in. We have convened our ethics committee to discuss crisis standards of care and have put together a ethical guideline decision-making tree for our providers and our staff. If for one reason or another we may not have the supplies or equipment to care for patients coming through, but at this time we have all the resources, equipment to care for our patients. The ability to test all symptomatic people quickly, yes, it's gotten better throughout the region. Currently we're about 1 to 3 days. Occasionally we get it within 24 hours, but it all depends on the weekend. If a test is done on a Friday afternoon, generally we expect to see that result to come back on Monday. In the coming weeks, we do plan on having 24 hours results more frequently, and in the future as well, same day results. As those test cartridges or kits become readily available, we'll have the ability to test more efficiently. Ability to test all contacts quickly. This is a public health responsibility. They're currently using Northwest Pathology out of Bellingham, and their lab has a 1 to 2 day turnaround. The ability to conduct active monitoring of all confirmed cases, again, that's a public health. And the ability to test healthcare workers and workers in essential roles and provide adequate PPE. We believe we have met that. The only criteria that we're really concerned about is making sure that we have a sustained reduction in positive cases over a period of time. Once that occurs, we feel comfortable, yes. In general, we like to see the next step in society open as well. And then finally, that final phase of a pandemic is treatment and finding an effective way to treat and provide a safe vaccine for our population. And that we do know is many months ahead, if not 18 months from now as they develop that. But we'll have an opportunity to talk to Dr. Preston a little bit later on in our discussion. There's been a lot of conversations about testing, whether that's been calls to the hospital, questions via email, or even through social media. We prioritize and we test based off of CDC guidelines. The cornerstone of our testing is COVID symptom-based and a clinical picture from our provider. There is a priority in testing, and it starts out with those that are the sickest of the sick. Also supports our hospital and first responders, high-risk patients with underlying conditions. Then it moves toward more of minor symptoms, and then individuals without symptoms. This right here is guidance of CDC. It is filtered through each state to the public health. In our region, much like our other 2 county hospitals, we are still testing only symptomatic patients with a positive clinical picture based off of provider discretion. This is a sheet to your left that's taken from the CDC that talks about the prioritization. Our hopes are in the near future we will stand up more testing for more symptoms and ultimately as a region test individuals without symptoms. Thinking just a moment ahead, many of our leaders here at the hospital daily spend time with our public health on one meeting or another. The formal announcement will be made probably in the paper this weekend in the Herald, talking about a drive-through clinic. And this drive-through testing clinic looks like it'll be opened in Mount Vernon. It'll be run by public health. It'll start out with high-risk individuals, first responders, and hospital personnel. The following week, it'll open up to the community. The scope of the testing, who gets tested, what symptoms, I've yet to see, but as soon as I see, we'll make sure that we get it rolled out to everybody. Really excited about telemedicine. This is not a capability that we've had in the past. It's something that we've dreamed about, especially because of our geographical location. When we look at the map, as many of you all know, our service area isn't just the Doggo Island or Guaymas. It really extends down to the Woodby area and throughout the San Juan Islands. And so telemedicine allows us to connect to our patients without that burden of the commute in many of their specialties: primary care, behavioral health, sleep medicine, sports medicine. Many of these services that we offer here in the future will be offered as telemedicine. Now, some cases can't be done through telemedicine very easily. And let's take a look at emergency department. Emergency department, you have a belly ache. Well, is your belly rigid? It's really hard to tell from a provider point of view some of those symptoms by spending time with our patients, touching, palpating, listen to the heart and their lungs. But we're going to do our very best to roll out telemedicine among many specialties and get this hardwired into our community so there's more service options for our region. Telemedicine or tele-ICU, I'm very excited about that as well. We've had about 6 or 7 vendors that we've looked at. We've narrowed it down to 4. And I'm about to narrow it down to the top 2, which is Swedish and Intercept Telemed. Both of the top 2 provide intensivists and ICU nurses coverage 24/7. It's going to take 3 or 4 weeks to get the basics stand up. It is a pricey endeavor. Ultimately, we believe when we do our business case that we're able to sustain a tele-ICU model moving forward and keeping folks local when it's within our scope of practice. But pretty excited about tele-ICU. I've known about tele-ICU and played with tele-ICU in my former past, and what a great service it is for rural hospitals. I want to pass this on to our COO, Ms. Ann Raish. Ann, are you on? One moment. Ann, can we hear you?
Yes, I'm on. Can you hear me?
Yes, ma'am. There you are. Ann, the floor is yours.
Okay. Well, we wanted to just spend a few minutes, again, reminding you of all of the strategies that we did put in place to keep us operating and available to the community during this time. I think it's important to know that we really tried to focus attention in some key areas. One, we needed to reduce exposure, both to our employees and patients, to anyone who might be coming in with this virus. So the first thing we did was begin screening at all entrances. And now we do that and we hand out masks for all. No one enters our facility unless they have their own mask for the day. If not, we're able to hand those out according to what kind of activity that they are involved in inside our clinics. We also have material masks, thanks to many of the community members that we hand out. If visitors, even though we have limited visitors, sometimes they do come and we are able to share those. We have decreased our visitation hours and continue to limit visitors. We have, as Charles has said, adopted the emergent urgent approach to all services. Just this past week, we've added testing of all patients prior to surgery, our procedures, or any of our patients in labor and delivery. It helps to understand how you might treat that patient, or maybe you would decide not to do that procedure. Definitely has impacts in labor and delivery. You're not going to stop labor and delivery, but it really does affect how our staff treats both mom and baby if they were to be found to be positive for COVID. So that's been a very helpful thing that we've started this week. And Charles just shared, we've expanded our telemedicine, which really gives us new approaches to manage those patients that are best really if they stay home. So it's been a wonderful addition. Another strategy that we implemented was developing alternate sites of care. We were successful in standing up our respiratory clinic. This is used to screen, evaluate, and treat anyone that has a respiratory type symptom. From the beginning, they have been able to allow patients, if they're not terribly sick or symptomatic, to stay in their car. And we will go out to the car and test you in the car. And we found that a lot of the OB really don't want to come into the clinic. So that's been great that we just go out to the car and test them, and they're very comfortable with that approach. We've expanded our call center. We have several trained nurses that answer those calls to assist with any COVID-19 concerns. And as Charles said, you know, if there comes a time where we need to do this in Anacortes, we are all ready. We have all the processes developed and the supplies to do mobile screening here at Island if that becomes a need. That truly is a process that's used mostly for the screening of asymptomatic individuals. As you can imagine, it's hard to do a physical assessment standing next to a window. So it's a great tool if you're screening asymptomatic patients. Another strategy that we employed was how do we address surge planning if we were to have a large amount of patients come to visit us, which, you know, I guess I would say luckily we've pretty much feel like we've been in this bubble. We've had cases, but we really haven't had a surge, but we've been ready. We have an ER tent that we added to address acute but not serious respiratory conditions. And we developed the capability to expand our ICU from 6 to 12 beds. And thanks to the donation, we were able to go out and obtain those additional ventilators. So right now we actually have an old one from the past, 8 new ones, and 3 more on the way. We also, as you heard, are in the process of expanding our ICU capability through tele-ICU. And we were successful in developing pools of nurses and even providers and gave them what we call just-in-time education to allow them to really train up to a higher level of maybe performance than they've had in the past, so that we have enough physicians to manage those acute patients in the ICU, as well as nurses to support them too. We have expanded our rapid testing capabilities. As Charles said, we mostly use right now Northwest Pathology in Bellingham. They are a site for PCR rapid testing. That's the polymerase chain reaction, a molecular test that really tests for RNA for that virus. For the most part, since they've been up now for about 2 weeks, they're getting their results back to us in 24 hours. That's who we're using to do all of our inpatient testing of our OR and acute care and OBGYN patients. We also use LabCorp. They do virology testing. They're a large national firm. They opened a second site in Phoenix, and they actually have been returning all results within 48 hours. So unless it's an acute issue, most of our testing from the respiratory clinic goes down to Phoenix through LabCorp. We do have the Cepheid PCR instrumentation in-house, but we're still awaiting cartridge supplies. We've been told that we should have those by next week. That would be wonderful because test turnaround is about 45 minutes for the Cepheid testing. We also have an Abbott point of service instrumentation, but we do not have the supplies to do the Abbott point of testing. We're on a waiting list for that as well. We hope to add immunology or antibody testing. Those are serology tests that really measure antibodies like IgG, IgM in your blood. They can reveal if you have immunity. These have been slow to come out because what you find is that there's a very high false positive in these tests. And so far, the FDA's only approved one lab to do these immunology tests, but I'm sure within the next couple weeks, there'll be many more, and that will really help us as we move to start opening up and getting back to some semblance of normal activity. We also hopefully have been able to keep everyone up to date by communicating both our internal and external audiences. We do daily updates to employees and providers. We actively cooperate with several media outlets. We regularly post on Facebook. We have a new webpage, and any resource that we come across that one of our audiences or community groups would benefit from, we try and post on our site. And as Jeanette showed you, we have received numerous community donations of supplies and food, and that's been very much appreciated by all of our staff. I think that may be my last slide, and I think we're moving on to Elise, who's going to tell you a little bit more about the financial situation here.
Thank you, Ann. I appreciate that. Hello, everybody, and thank you for joining us. I'm going to give you some updates on some of the funding pieces related to the COVID crisis and the financial assistance and how it's impacting us here at Island Hospital. As we discussed on our last call, there was the CARES Act, or the third stimulus package, package number 3 was passed, and it promised to deliver $100 billion to hospitals. And at that time, when we had our last update, there were no clear criteria on how that was to be distributed. Since then, the federal government has distributed $30 billion of the $100 billion to hospitals based on your percentage of overall Medicare payments nationwide. So for Island Hospital, we did receive $2.1 million on the 10th, on April 10th. That equates to about 2 weeks of lost revenue, just to put it in perspective. So our big concern now is, well, what about the $70 billion? We are grateful for the $2.1 million that we received, but what about the remaining 70% of these funds that haven't been distributed yet? We're still waiting to hear how those will be distributed, and our major concern really is that those funds will be directed to large institutions who have really cared for the highest number of COVID patients. And we understand, obviously, why that would be done. Those hospitals are bearing that burden. But we are advocating and working with our state and federal legislators to really recognize that for rural hospitals or smaller hospitals, although we may not be kind of the epicenter of the COVID crisis, by shutting down over 50% of what we do, it really puts a strain on us from a financial standpoint. So we're still, again, waiting to hear about the other 70% of the CARES Act release. There were also a few other items in that CARES Act, which was the 2% withhold, or it was known as sequestration. So prior to the CARES Act, 2% of every Medicare payment we received was withheld and kept by CMS or the federal government. That was a holdover from a few budget battles a few years back. And they are waiving sequestration through the end of the year, which again sounds great, but it really has minimal impact for us because we have such little volume now coming through the hospital that 2% of something very small is only about $20,000 or so a month. Our Medicare accelerated payments, we talked about this last time. Medicare is allowing hospitals to request up to 6 months of your anticipated receivables in advance. We were allowed to use basically 6 months of our 2019 payments, so we have submitted that request. We haven't heard back. You're supposed to hear back within a week, and we're just about at a week, and we haven't heard anything. Our concern with this is it'll be a great injection of cash into the organization. However, within 120 days, or 120 days after we receive the funds, Medicare stops paying us any payments from that point forward until this is paid back to them. So again, it's a good, quick injection of cash, but then what it does is we have to pay it back within a year. So 120 days from receipt, they cease all future Medicare payments until the balance is paid back. Again, we're working with our federal legislators, on this to see if there can be, one, a longer timeline, because 4 months is really not enough for us to make up that much revenue to pay back CMS, but also is there some other way, some forgiveness, or again, some longer time frame than a year to pay it back. So again, we'd have to start paying it back at 4 months, and then we only have up to a year to pay it back. So we're advocating for a longer timeline to pay it back, and also they have a very high interest rate tacked on if you default or go past a year. The payroll tax deferral, we talked about this last time. We have begun that deferral, which means we do not have to remit to our FICA payments to the federal government, but again, this is a payback, so it's basically a loan, and we will have to pay that half back in 2021 and the other back in 2022. And then we received some funds from the state that we were going to receive in September, and we received those with a few hundred thousand dollars that we received early. So overall, really what we're seeing out of this is really just the $2.1 million, and I do feel a little guilty of saying just $2.1 million, but when we look at the overall impact of this COVID crisis, again, that's only about 2 weeks worth of revenue. FEMA, we've learned a little bit more since we last spoke about FEMA reimbursement. What we're learning is it is very restrictive. So it's really not designed for a pandemic like this. It's designed for natural disasters, and it's very, again, restrictive and specific. So they will reimburse 75% of new costs associated with this crisis. And what does that mean? So they'll reimburse us for things like temporary facilities, so the cost for us to put up our tents, perhaps. Some PPE, so not all the PPE that we're buying, but specific for using those extra medical facilities. Again, very specific. And then they will not reimburse for any existing costs. So for example, here at the hospital, you heard Charles talk about how we reacted pretty quickly when we reduced services and had to furlough some staff. Well, some people are still here working in a new role. So to work on our incident command team, and basically FEMA is saying if they were somebody that worked for you before, regardless of what their new role is, you will not get any reimbursement from that. So that was disappointing to hear, because much like any of you that have run a business, you think on your feet and you redeploy resources where you can, and in this case, from FEMA's perspective, those are not considered, quote, new resources. And again, they won't, the second bullet point, they will not reimburse for any lost revenue, just expenses. This next slide came from a presentation or a webinar that I participated in about a week or so ago, but I thought it was a really good visual to show, one, we shared it with our federal delegation so they could see it. But if you take a look, and I pulled my mouse out, so hopefully you can see what I'm doing. But basically they're saying when we take a look at the lost volume, they're saying 65% of our lost revenue is coming from the decrease in elective surgeries, and then 35% of the lost revenue is coming from a decrease in emergency department volume. And just to put that in perspective, when we take a look at our emergency department, our emergency department visits are down by 41% compared to last year, same month last year. And we look at our revenue, our daily revenue, our revenue is down about 54% from the same time last year. So again, we are experiencing just what they're talking about here. Decrease in revenue from the no elective services, and then the decrease in our ED or emergency department volume. These blue squares here across the bottom show of the federal packages that have been passed, the CARES Act and a few others, really, are they making up the loss? So you can see here, we talk about the increased volume and reimbursement for COVID cases. They're saying, well, you would get 2% of your losses back. Well, for us, it's less than that because we haven't had that many inpatient COVID cases. So that may be true for a facility that's closer to the epicenter. And then you can see for these other squares, they're talking about the suspension of the sequestration, the delay in some other reductions that CMS was going to put through. And then this 23% here, this stands for the Public Health and Social Services Emergency Fund, which is what the CARES Act is referring to, says it's only going to make up about 23% of your losses. And for us, as I told you, it was only 2.1 million, so significantly less. But for the average larger hospital, what they're saying and their research has shown as they've modeled it out, hospitals are still left with 63% of the shortfall to cover out of their own cash reserve or through a line of credit or new debt service. So again, it really was just a good illustration, I thought, for us to really look at. Here you can see the magnitude of the loss and then these small incremental offsets that the federal government has put in place so far. Now, if you've been listening to the news, you know that they're working on the next stimulus package number, excuse me, I dropped my mic. They're working on the next stimulus package, number 4. So we're really waiting to hear, depending on probably which news channel you listen to or which congressman you listen to, the priorities are hospitals, government, or small businesses. So we're hopeful that we won't get left out of that mix in this CARE package, or excuse me, CARES Act number 4. So thank you very much for your time, and I'm going to turn this back over to Jeanette.
Hi, everyone. We're just have one more slide, and then we received so many questions in advance, which we then incorporated into the presentation, and then some we've left for the end that the experts can answer for you directly. But some immediate needs that we still have, with setting up the respiratory clinic to have a safe place and handle more volume and for testing. We have dedicated staffing to that, and there's those costs to set that up and to keep it running. We also have that net loss. 65% of the crisis has been funded that Elise just spoke about. And then we have some recovery costs and restanding up services costs. We had planned to bring back services that the community has asked for repeatedly and are really needed, and one is the urology program. And we have Dr. Tepwich, the urologist here, that will be serving Island Hospital. And to get that program up and running, we need to create some clinic space for him to be able to do these procedures, and also some equipment with new scopes to be able to handle the different specialties. He works with bladder and so forth. We also have a huge backlog with gastrointestinal specialties and screenings, from colonoscopies, endoscopies. A lot of those preventive screenings in our county was up to 6 months to a year behind, and then the American Cancer Society is actually saying that we should not be, we should be lowering the requirement to actually do screenings at age 40, not 50. And when it was at 50, we were very behind. So we have a plan to get gastrointestinal going and to be able to address some of those screenings and testings you all need. So those are some financial needs we have as well. Next, we're going to get to our questions, and one of the first questions was, and I think Gary, Dr. Preston, this one's for you. The writer wrote that as someone who had COVID, is there availability of retesting to make sure it's out of someone's system, theoretically allow them to go back to work? Gary, help us with that?
Many of the questions have to do with testing, and I wanted to expand very quickly on a couple of points that Charles and Ann made, and that relates to the role of testing in our return to normal strategy. The PCR testing detects viral RNA. That would be a piece of the virus or pieces of the virus that are detected whether the virus is intact or not. And that components of the virus that are in essentially cellular wreckage as the host improves and clears itself of the virus, it will still be there and protected. So what is unclear is the relationship of communicability to positive test results. So that's an important piece when you consider what the test is really telling you. The other test is the antibody test, which detects evidence of an immune response against viral components. And there is that it needs to be known which antibody against which viral components provide immunity and for how long. That is not clear. So these tests, while already in our hands or soon to be in our hands, will need to be well understood if we're to use them effectively in guiding our return to normal. The question here is, well, when can I return to work? And there are CDC guidelines. I'll provide the link that you can post and send along with the presentation. Bases the return to work on the resolution of symptoms and timing from the date of onset of symptoms. So 3 days or 72 hours since the resolution of fever without any fever reducing medications and improvement of respiratory symptoms, and 7 days from the onset of symptoms if testing is not used. If testing is used as a measure, then 2 negative COVID-19 test results 24 hours apart are in the recommendation. That is, we're having trouble having enough testing capability to support even diagnosis, let alone testing every worker before return to work twice before that return to work. I frankly think that basing return to work on test results will not be happening because it's not supportable and likely is not necessary. So the 7 days past first symptom onset and 72 hours since symptom resolution, whichever's longest, is a more practical approach and very similar to that we use for influenza.
Okay, Gary, Dr. Preston, I have another question for you. It's number 6 on your list. It says, I know there is not a consensus on the COVID-19 antibody test, but I'd still like to know if FDA-approved tests from Chembio, Diagnostic Systems, Celix, and Ortho-Clinical Diagnostics will be offered, at what price, and if a doctor's order is needed to be obtained first. Then the second part is if Abbott Laboratories is also FDA approved soon, this will add a 4th FDA approved manufacturer to the market. As you know, even without explicit FDA approval, Abbott and dozens of other companies may be distributing tests given the regulatory flexibility right now. Wondering if Island Hospital has position on if they'll only use FDA approved tests or if they'll make an informed decision by the manufacturer. I've heard the price point is anywhere between $20 to $70 per test at this point in communities that are offering this.
Knowledgeable question for which there are no knowledgeable answers at this point. As I mentioned, the strategy for use of these tests is going to have to be community or state-based if we're to appropriately steward our testing resources and rationally manage the return to normalcy based on test results. There will have to be some methodical population-based application of these tests if we're to, first of all, understand what they're telling us, and second, use them in some economical and resource preserving way to return to normalcy. I have no idea what the ultimate cost will be. We do have a pharmaceutics committee and methodical ways to evaluate new technologies, including these as they are proposed. And I suspect we'll be using those resources and tools to evaluate the choices.
Charles, I have for you is, are you reporting positive cases when the test results come back positive or when the test is taken and later reported positive? Can Island Hospital speak in regards to how other Skagit County hospitals are also reporting?
I can comment on that. Positive results are reported to Skagit County Public Health, and they've provided all the hospital template that they've asked us to use to report our results daily.
All right, thank you, Dr. Preston, on that part. I think that's regional across the board. As we take tests and as our lab vendor sends a negative or a positive, that positive is then reported to public health and then put on the public website, generally within 24 to 48 hours. I know as we take a look at these websites and try to understand how real-time they are, what I've noticed in the various websites is generally is a lag of a day to 2 days, especially if it comes to a weekend. I've also found that occasionally they'll have technical difficulties, IT challenges, and so that puts them a little bit further behind than what we would like. But for the most part, this region is about up to date within 1 to 2 days.
Okay, next question I think is for you, Charles, too. Of all those hospitalized, how many were Anacortes residents? That was the average hospital stay for those recovering. How many active COVID patients are currently hospitalized at Island Hospital?
Question. Well, there are some HIPAA challenges that patient privacy challenges that I do want to make sure that we embrace and respect. I'm okay with giving a broad answer to that. I did count up the number of patients, the 22 patients, and where they were located. The best way for me to say it is about 60% of positive cases are in our hospital district area. And so as we study our hospital district, it is Fidalgo Island, it is Guimas, it is, that's about it right there on that part. So about 60% of our total positive cases. Besides that, I can't give any further comment on it. As far as how many are inpatient right now, as of right now, there are 0 inpatient cases. And many of our, actually some of our inpatient cases have been tested, discharged, and then the positive result comes where we have to call the patient and notify public health. Good question.
Okay, Ann, I have the next question for you, and it's about availability of PPE. Seems to be a question, as if our healthcare workers protected, and an update on specific PPE needs and costs would be most helpful.
We've been fortunate in that we were able to obtain adequate supplies of PPE. We got to a point where we were getting concerned about our N95 masks, so we actually found a vendor who was working with VM and was willing to purchase some N95s from the China market, and that actually was delivered this past week. So I would tell you, with our current use rate, we have a significant supply of PPE. But as Charles mentioned, once we start opening up business as how we usually did that and had quite a bit more surgeries and procedures, our use rate will double and triple. So that's when we have to start getting concerned about our getting supply has been challenging. So we're hopeful that as things open up, there's just a broader market for supply. One thing we have also found is that there are quite a few new ways out to re-sterilize the N95 masks, of which we have demoed one using some of our own instrumentation in-house. So we can now re-sterilize our N95 masks in-house. So that's wonderful. So right now things look good for Island and then what I think there was a question about the cost of PPE, which varies by this the amount that we order. I mean, most vendors give you a volume discount, but I think if you see someone dressed up in their PPE, you can easily know that that probably cost about at least $20 to $25 to put that person in PPE. So it's not a cheap system for us to use or for any of us. And you think about that across this country. The other piece I worry about is where's all that waste going to go, the PPE waste. And that's something yet that we'll all be working on, I'm sure.
The details that has influenced our burn through PPE has been length of stay of our positive patients, which was part of an earlier question. We have had 5 patients, inpatients test positive, and the length of stay of those patients has been no longer than 3 days. One patient with 1, 2 with 2, 2 with 3 days. We had one patient transferred in as positive who had a length of stay of 6 days, and that's the longest stay we've had, which really lightens the PPE burden considerably.
Gary, while I have you, somebody chatted a question, and it says Skagit County is showing 77 recovered patients. Are they being actively invited to provide blood/serum for clinical use?
I don't believe there's a public health mounted campaign yet to collect serum from those who have recovered, but I would hope that there'll be a methodical approach to that that will provide some information about or answers to some of those questions regarding immunity that I posed. That's a great question.
Okay. Before we get into some of the financial questions and telemed questions with Elise, I have another one, a couple for Charles here. When will the Washington statistics start showing recoveries so that the active cases number is correct?
That's a great question as well. As I've studied the different websites, whether it's the Hopkins site or the Wichita site or the Department of Health or the Skagit, the recoveries for Skagit County, the only website that I've been able to find is the Skagit Public Health that articulates the number of recoveries. Out of the positive 218, 75 have recovered. How accurate that is, I can definitely dive in and talk with both Wisha and Skagit County to assure its accuracy and get back to the center of that question.
Have another chat question, and do we have a local opportunity to donate blood? I know there was some conversation about that. Anne, are you aware of that one? Or did, we can get back to you on that. There was some conversation about that last week.
Dennis is working on a mobile unit.
We're working on a mobile unit, and we will then send that out to via email when we have that information. Okay, I have, let's see here. Few more questions. I think they're for Elise, actually. After reading, this was from last week, the Anacortes American last week, is there a cheat sheet for telemed with simple steps showing how to do it for those who have not ventured there before?
Great question. For our patients, we've been reaching out in this initial wave to patients whose appointments were previously canceled. So what we're doing is we basically work with you about 48 hours before your appointment with a one-on-one session with one of our schedulers, and he or she will walk you through getting logged on and basically doing a dry run. So that way, when it comes time for your appointment with your physician, you are ready to go. As far as the cheat sheet, we do have instructions on our website that you can go to. I know some of you also use Island Medicine or Island Family Physicians as your primary care docs, and they also have instructions on their website because they do use a different platform than we use. So again, if you're working with Island Family Physicians, Dr. Rieger's practice, Meg Sweeney, they have a slightly different process due to their platform. But as far as for our patients, we are scheduling time about 48 hours before your appointment to do a dry run with you so you can get everything up and going. The challenges have really not been with VC, which is the software we're using. It's been just getting people's computers, iPhones, iPads, or laptops set up to have the cameras working and the microphones working. Much same challenges like we're having with WebEx as we all learn to use this this new way of meeting as well.
Okay, we're down to the last couple questions. For Elise, would the economic impact have been mitigated if Island Hospital was part of a broader network like Peace Health?
Another good question. I think this was from Chuck Gonova, my fellow Villanova grad. I have to say, it wouldn't have been any different as we're on, and Charles can speak to this as well, we're on multiple calls with all different size hospitals, whether they're a system like Peace Health or Providence or a small rural hospital on east of the mountains. Everybody is dipping into their cash reserves to pay for this crisis. Again, some of these hospitals have been dealing with this crisis since late February, early March, and the first dollars came to hospitals on the 10th of April. So again, being part of a system doesn't mean that the cost to each hospital proportionally are any less. Everybody's dipping into their cash reserves.
This is Charles. Let me add a little bit on to that. I know that contractually we don't have agreements or system alignments with larger organizations. Probably 2 to 3 times a week, many of our leaders get together with Skagit as well as Peace Health to talk about how do we standardize our approach, what policies or practices have you put into place so there's an attempt for a unified practice across our county. Conversations have also led to what resources do you need, how can I help you as we tackle this together. Come next Monday, we'll have another conversation between myself and the 2 chief executives of Peace and Skagit to continue the conversation. How do we respond together in a unified way to tackle this virus?
Okay, I have another question that came from those typing in our chat box, and it's for Gary. Dr. Preston, is there any analysis or interpretation of the Skagit County test results where we are only testing symptomatic persons yet getting 91% negative results?
I'm not sure I understand the question quite. It's definitely true that there are if tests are applied without regard to symptoms, a number of folks who test positive do develop symptoms within a week. But as I mentioned, it's not clear which of those patients will develop symptoms, which won't, who won't, and who have already essentially transited the infection and are resolving it, and that test result, that positive result, reflects the as I mentioned, the cellular wreckage that I mentioned. So I'm not sure. It is true that um, if there is a large portion of folks who are communicable asymptomatic, that's going to be a problem when it comes to design the strategy for return to normalcy. And as Charles said and showed, the CDC and other strategies for using testing is based on the presence of symptoms. That apparent disconnect is going to need to be resolved as we go into the return to normalcy mode. If we're to rationally apply testing, I can say that it's as experience with testing has matured, the time where positive results without symptoms appears to be significant has been reduced. Previously, it was thought to be many days before development of symptoms. Now it's thought about 48 hours. And I think the understanding will be tightened up on the other end as well. But there's going to have to be some clarification of or understanding of when infectious virus is present and how does that relate to the PCR positivity and the development of symptoms if we're going to use development of symptoms as the marker and indication for testing. That's a great question. Assuming I understood it correctly.
Thank you for your answers. That was, yeah, great information. Janie, any other questions coming through on the chat?
One comment says, I think Steve may have been asking why so many apparently positive people tested negative.
Okay. I think the person was asking why so many positive people are testing negative, appearing positive, people testing negative. Appearing positive.
Positive people.
Sorry, yes. Well, there are plenty of organisms and reasons for folks to present with respiratory symptoms, everything from alder pollen to influenza, respiratory syncytial virus, rhinovirus, adenovirus, or other common coronaviruses that cause respiratory symptoms. So that was part of the dilemma as we went into this, and was, well, how many test batteries need to be done along with COVID-19 if we're to appropriately and efficiently evaluate patients who present with symptoms. You typically only want to perform a laboratory test if the result is going to influence your management. And for many of these situations, it really doesn't. You're not going to treat the patient differently given the result. And the expense of these tests is not trivial. So it's a very important question and is going to need to be better answered if we're going to rationally apply these tests as we attempt to go normal.
Okay. I think we got all the questions answered, and really thank you for being with us this afternoon. And if you do have other questions, just email us directly and we'll get you the answers one-on-one. And if you do want to discuss about, get more information about any of the slides or need more information, just contact us. Thanks so much. Have a great weekend.